Welcome to the Q. My name is Nurse Bug. I'm your friendly neighborhood nurse surveyor.
Hey, y'all, it's Amanda. Thanks for listening.
Hey, I'm John Pouliot, and I'm your friendly neighborhood consultant pharmacist.
Today's podcast is all going to be about de-prescribing psychotropics and antipsychotics. And we have a guest speaker. His name is Jonathan Pouliot. He is our, what was your title on our podcast? Your friendly neighborhood pharmacist?
Yeah.
We're going to talk about de-prescribing with him. And I found an article that talks about the increase in antipsychotic prescribing for residents with dementia that was raising concerns. And it was mostly during the pandemic. So there were concerns for the persistence of the pandemic-associated increases within the first 2 years of the pandemic in antipsychotics and antidepressant medications used in dementia care settings. So antipsychotics were used frequently, and it increased to a larger degree than even antidepressants, with approximately 8% higher use for memory care residents or dementia care residents. There were some challenges faced by nursing homes during the pandemic, partially explained the increase in the meds. Staffing shortages, declines in services, comprehensive integrated care, loss of caregivers, increase in pain, mental health conditions due to restrictions with room restrictions, and difficulties implementing non-pharmacological interventions to address their mental health concerns and behaviors instead of just adding a medication. The increase in the antipsychotic prescribing was likely inappropriate. There was lack of non-pharmacological alternatives, and it supported the short-term use of antidepressants and antipsychotics, but it still remained elevated. Meds tend to persist beyond the appropriate period of treatment during that time. It's been a trend. We're staying with that. But they're trying to get away from that now with all the changes with CMS and, polypharmacy, especially with our elderly. We just want to educate on the proper use of these medications and innovative tech if that can be used instead, the non-pharmacologicals. Because it doesn't just include, a massage or something like that, but tech things as well. So, John, I'll let you talk about the steps of successful de-prescribing.
Thanks. Thank you for that introduction. I think it's helpful for us to see the landscape. During the pandemic, it obviously created a huge strain on this particular patient population and care for this particular patient population. And in addition to challenges faced by long-term care facilities, there also were additional challenges faced by patients. And so their psychological health suffered because of some of the policies and some of the things that were going on, stress and fear about it. And so it created this really difficult situation for everyone involved. And so when thinking about de-prescribing and specifically antipsychotic medications, it's important to make sure that we maybe define what inappropriate means. And so antipsychotics are a broad range of medications, but really they should only be used for a very select group of patients and a select group of diagnoses, really related to schizophrenia, schizoaffective disorder, and some other related conditions. And so using medications outside of those FDA approved indications is why we see this rise in what we call inappropriate medications. The other part of antipsychotic use is that they are associated with side effects that may on their face seem beneficial. So antipsychotics can cause sedation and they can cause patients to be a little bit more calm. And sometimes that can be seen as treating behaviors. But we know that antipsychotics, that sedation, that calmness is really a side effect and not actually helping the patient. And then we also know that antipsychotics, and this is well documented in the literature, are associated with increased mortality, especially in dementia patients. And so when we give antipsychotics to dementia patients with behaviors to try to help with the behaviors, we're actually potentially causing harm. We're using the drugs for their side effects and not for their intended use. And so when we think about de-prescribing, it's important for us to understand when we should use drugs and when we should try to refrain from using drugs that may look like they're helping the patient, but actually are causing more potential harm than good. And so when we think about this, we're really thinking about trying to identify patients, trying to identify residents that are at most risk for polypharmacy. So what we mean by polypharmacy is patients that have multiple medical conditions, Maybe there's some legacy prescribing. They've gone from the hospital to the facility to a different facility, and they can kind of snowball accumulate medications. And then we have complexity in prescription regimens as well. And this all contributes to polypharmacy. What we get with polypharmacy is not only the side effects from the individual medications, but additive effects. And so, if somebody is on an antipsychotic plus an antidepressant plus some other medications, it can cause drowsiness and sedation. It can cause sleep deprivation. Even though the patient looks like they're sleeping, their sleep quality is poor. They can also cause GI issues, and that can result in negative effects for the patient. So, falls, confusion, and then just really general decline. When we think about de-prescribing, we really want to focus on patients that are at risk of polypharmacy or are currently in the middle of having polypharmacy. And so we want to think about de-prescribing, tapering, stopping, and discontinuing meds. And that's really an effective tool to combat polypharmacy. But it also depends on thinking about the drugs themselves. Some drugs you can stop right away and there's no negative effects. Some drugs need to be tapered so that their effects and even their side effects can be kind of tapered off over a period of time, especially psychoactive medications. So this is really an appropriate way for us to go forward, trying to involve our staff, our residents, our families that are involved on the decision-making process, understanding the process, and understanding the risks and benefits of the process. So the first step is to determine if you have a problem. So you want to review the patient's meds, work with your pharmacist, your consultant pharmacist, or other resources that you have to do a complete review of the patient's regimen. Determine if the medications are still necessary. Do the medications, one easy thing, do the medications that are on the patient match with documented, confirmed diagnoses? And are those diagnoses appropriate for the medication? So the antipsychotics. If the patient has dementia with behaviors, that is an inappropriate indication. And so first making sure that they are still necessary, make sure that they're actually benefiting the resident and not just like, oh, this patient has behaviors, let's this medication seems to decrease behaviors because it's causing sedation and confusion, but actually helping the patients. And then looking for combinations of medications that could increase the risk of adverse events. And ultimately, you want your medication regimen to align with the goals of care. So once a comprehensive medication review is done, then it becomes time like, how do we actually create and implement a de-prescribing plan? And again, a pharmacist is going to be really helpful to determine when the meds can be stopped, if they can be stopped, or if they need to be reduced, and develop a schedule, develop a plan for tapering medications that need to be reduced. Another thing that we see when you're doing a med review that could be an issue is, are you giving medications to treat a side effect of another medication? And so that's another way polypharmacy can get out of control. So thinking about a de-prescribing plan. So if you're on an antipsychotic and they're having side effects from that, as you're decreasing the antipsychotic, you might be able to get rid of other medications that are treating the adverse effects of the medication. Making sure, and CMS has really emphasized this recently, making sure that the resident and the family are informed that they are part of the plan for de-prescribing is going to be very important. And then as you're de-prescribing, whether that is stopping medications or tapering medications, think about how to monitor for effectiveness. So what condition do they have? Is their condition getting better or worse when we de-prescribe? Are other conditions getting better or worse? Thinking about the adverse effects that are associated with the medication, but also with withdrawal, and then supporting the resident throughout the process to ensure. And then while you're doing this, it's incredibly important to document. So with antipsychotics, we generally recommend a gradual dose reduction strategy. And gradual dose reduction has been studied in the literature and is safe and effective at getting medications discontinued from patients, but also finding an optimal dose that is minimizing the adverse effects and maximizing the effectiveness of the medication. Documenting across that whole process is going to be very essential. Documenting the response the patient's having, documenting what the plan is for dose reduction, and documenting why you're doing this. Why are you de-prescribing this medication? Thinking about some of the changes to the regimen, is there opportunity for decreasing pill burden? What are the outcomes? And then recording that across the board. That's going to be helpful for obviously regulatory compliance. It's going to be helpful for handoffs in your facility between staff. It's going to be helpful for the medical director to have clear documentation. Those are kind of the big steps for de-prescribing. You can also use the frame approach. This helps the resident feel more comfortable with the process, remind them that they're important and their voice matters. We don't really want to walk into a patient's room or a resident's room and just say, "You're off all your medications," and I said so. If you just do it that way, you're going to create mistrust in a patient population that might be feeling mistrust. You might get abandonment. They might feel abandoned. They might feel a sense of like, well, these medications are what's keeping me alive, maybe, or what's keeping me sane. So there could be a sense of medical team is giving up on them. And so you want to make sure your residents and families, in some cases, understand the goals of care, making sure that the recommendations that you're making with de-prescribing are aligning with the residents' goals. Also, that they are aligning with what is best for the patient. So education is going to be very important as part of this. Why are you doing this? It might not make sense, but here's why. Here's a really good explanation for what's going on. Patients, and speaking as a pharmacist, patients think medications always are going to make them better. And that's a cultural thing. That's especially in the culture, the type of cultures that you're dealing with in most long-term care facilities. They think a medication is going to make them better, not worse. And so when you have to go and talk to them about a medication that's potentially harmful to them, maybe not tomorrow, maybe not next week, but in the future, it's really important to make sure that you're empowering them and helping them understand the importance of this. And then making sure you're scheduling future conversations. It's important to think about ways to do this education. The motivational interviewing model is a really good way to do that. And there's even technology around motivational interviewing that can help the resident feel like they're involved, feel like they're in control, feel like you have what's best for them, and walk through that process with them. Consultant pharmacists can help. Many of the symptoms that patients may be feeling, maybe think that it's their disease state when it's actually polypharmacy. Thinking through that root cause analysis for how to de-prescribe and how to identify opportunities to de-prescribe. When we think about de-prescribing, I think some people knee-jerk can say, well, I just need to stop using medications. And that's not the case. Medications are very helpful. Hear it from a pharmacist. Medications are helpful. But not all medications are always helpful for all patients, right? So thinking about what medications are most helping the patient, leave those alone and focus on the medications that are low-hanging fruit first. That will help you build rapport with the resident and their families, and it will help you be able to make more concrete movement on de-prescribing and removing polypharmacy over the course of time. That's kind of the big sales pitch, I guess, for de-prescribing and the importance of it. And so that's what we got.
Yes, exactly. Talking with the resident's family, all of that is super important for them to understand, because once you're on a med, some people think, oh, well, I'm just going to be on that forever. Well, not always. Sometimes you have to be reevaluated. And I mean, that's especially true with antidepressants, antipsychotics, the psychotropics for anxiety, those are all, some can be short term, and that's okay. Some are long term. And I mean, I know I have anxiety. And who knows, I don't take anything for it, but maybe when I get older, maybe I might need to, but it won't be something long-standing, it'll be something new for me. Everyone's different, you have to kind of cater to what each person is individually feeling and going through. Thank
Yeah.
you for that explanation, John. I think that really kind of pinpointed how de-prescribing should go. And I like that you said tapering too, because I've seen in a lot of my surveying, I have seen doctors literally just cut it off. And I'm like, did they really think that was a good idea? Because the minute you take away that med that they've been on for years, it's turmoil. So tapering, it seems like it should be a duh thing, but it's not.
And some residents, it might be like if you're on the lowest possible dose of a medication and tapering is not actually feasible, then it makes sense to stop it. But not having a conversation first is going to be detrimental, right? So having a patient that's on a moderate to high dose of a medication that you want to taper off, they sometimes are not even familiar with the milligram dose They just know the name of the drug that they've been taking every day. And so talking to them about, we're going to keep you on this medication and we just want to see if there's a better dose that could work for you is a good way to kind of start it. So they're still getting the muscle memory, the routine of having their medication every day, but you're potentially decreasing the dose over that period of time and it's not causing as much turmoil for them.
I did want to chat a little bit about the testing that they do. I know, Amanda, you know about this and you advocate for it.
I do. My facility that was 1 star was a special focus candidate facility. Unfortunately, there had been years and years of mismanagement medications, especially to psychotropic medications. So I had to figure out a way to start. And my consultant pharmacist and I came up with DNA testing. So we moved in a methodical way. The area as to which I practiced was very culturally strong. John mentioned prior about muscle memory. So getting that medication is what mom had gotten for years and years and years. So I had to come up with a way to explain, hey, mom's medication may not be the best and it might be causing some of these symptoms, but it was really culturally difficult to break that. So what we did is we did DNA testing on each one of the residents that were on psychotropic medications. Now, at this point in time, and this has been 3 years ago, 4 now, Medicare Part D paid for this type of testing. So it would just be dependent on state, etc. So we were able to do that, and we were able to methodically, in a systematic manner, take medications away, but we were also able to explain it on many different levels to many different people. And that really helped because your DNA doesn't lie. But I do caution you on this because when you get a report, your resident might be on a certain medication that it says their body does not adjust to. I really caution on that. John mentioned this prior, like, and so did Lindsay. You can't just go taking things away from people. It doesn't work like that. You have to be very slow, and it's really important that you do things one at a time because you don't know what's working and what's not working. Even if you do have a DNA test, and there's a medication that's in the red or is in the yellow, like, don't use or talk about using. If that resident is stable on that medication and that's the least of your concerns, then that's probably not the best place for you to start. John, you want to chime into that?
I think the testing and the technology around the testing, it's important to think about them as a tool and not as
Yes.
a absolute guidance no matter what. And they can be helpful in patients that do have an indication for like a schizophrenia patient, schizoaffective disorder, that
Yes.
do have an indication for antipsychotics if you're just not getting the results that you expect. So this isn't just for deprescribing, but it can be used as a tool to help guide you in deprescribing, but also as a tool to help educate the resident and the family of, this medication actually, according to this report, isn't actually benefiting like we think it is. And they might just be experiencing side effects that we think are effectiveness.
Right.
Yeah.
Exactly. Exactly. Not a one size fits all for sure. John and Lindsay, thank you guys so much for joining in today's podcast and talking about deprescribing antipsychotics. Qsource can guide you in compliance regulations laid out by CMS, including the appropriate use of antipsychotics and psychotropic medications for your residents. As for our past webinar this past month of April, as John was talking about, your medical director, antipsychotic, De-Prescribing, and psychotropics. So this is just a counterpart to the webinar. So John and Lindsay, both, thank you so much for your guidance. Don't forget, if you do have a resident that's on psychotropic medications, antipsychotics, they've had a change in their medical diagnosis, or they have a supporting diagnosis for the use of that, don't forget to make sure that your PASRs are complete. You want to make sure that your GDRs are being attempted appropriately in an in timely manner. There are specific regulations related to GDRs. You want to make sure that you're and cares are up to date, and any interventions that are appropriate are in line with your residents' needs. That was consistently brought up between Lindsay and John. It is an individual tact approach. Not each resident can be prescribed the same thing, or can they be removed from the same medications. Qsource can help ensure that you provide the best care and assist in being survey ready as appropriate with antipsychotics and psychotropics. So if you need us, you know how to find us, book a meeting. We would love to collaborate with you and your team. All three of us would. So let's go into what our podcast is going to be for next time. For all of our MDS folks out there, our next podcast is going to be about MDS optimization. That is it. Thank you for joining the Q podcast for all your nursing home needs and topics. Until next time, have a great week. Bye, guys.
Bye, guys.